7 is one of those chapters you definitely want to review on a pretty regular basis and make sure you got a good handle on it. We talk about studying here in a few minutes. By minutes, I mean hours. I'm going to show you something I found in my Brady lab that may or may not be helpful to those of you that are having issues with definitions. Okay? I happen to be messing around and find it. It's a really good tool. It's kind of a fun little tool, and so I'll remind me to show you what that looks like. So this is going to go over ventilation, perfusion, and shock, right? The 3 things throughout this program that we're going to hit on a lot, okay? So introduction to pathophysiology. Today basically is all about kind of the normal and not normal things that happen with the body, okay? Like I said before, in order for you to actually diagnose or have a good idea of what's going on, you have to know what normal is so that you're able to recognize what not normal is, right? How many of you have taken any like pathophysiology classes or a little more advanced A&P and have an idea of this stuff? Okay? Use that really good foundation. Okay? So, the cell, basically you got lots and lots of cells, right? Groups of cells make up what? Tissues. Groups of tissues make up organs. Group of organs make up systems. Groups of systems make up a human, right? So that's kind of the breakdown of what we're looking at. Now, the cellular level stuff is important to a certain extent, okay? Remember, the 2 terms right here, mitochondria and ATP, are going to be something you're going to have to recall on a regular basis, okay? We're going to talk about ATP. We're going to talk about the purpose of mitochondria. We're going to talk about metabolism. That's going to be the really important stuff, okay? At the cellular level, there are certain specialized structures that are there that are extremely important. One of the biggest ones that I don't think we touch on enough is your sodium-potassium pump, okay? Someone tell me why your sodium-potassium pump is so important. Say again for us? Oh, sorry, it was you. Yeah, no electricity, right? So at the cellular level, your body's ability or your heart's ability for that automaticity starts with the sodium-potassium pump, okay? That's about as far into it as we go. Be thankful for that, because if you go onto the paramedic program, this is a little bit more lengthy, okay? But your sodium-potassium pump has that direct relationship with the way your heart contracts, okay? So here's the cell, right? Notice what it says right here. What does that say? Someone read that. Make sense? I'm just kidding, okay? You don't need to know that. Stop writing. Everyone stop right now. Scribble, scribble, scribble. Right? You should be able to recall the pretty major functions of a cell, but I promise you, unless I come to class in a really, really bad mood, this is not going to be on your test on Thursday. Okay? I like chocolate. I like coffee. Keep me out of being in a bad mood. Yeah. That might make me more angry, right? Especially if I don't know where they come from and there's firearms involved, and it'll just get real, real ugly. Sean is sorry. Okay, mitochondria, against the big one. Having a kind of decent understanding of the way the cell works, it's got a membrane that allows things to go in, allows things to go out. We're going to talk about the pressures here in just a second, but like I said, thank goodness we don't have to go horribly in depth when it comes to the cell. So water in the cell, right? There's this perfect balance, okay? If it's got the right amount of fluid, structures work like they're supposed to, that membrane works like it's supposed to, the cell operates just like it's meant to. If there's not enough water, dehydration occurs and the cell dies, right? If there's too much water, then those functions don't work properly, and then that lining or that protection has this permeability issue where things just flow in and out like they're not supposed to, okay? This is why water is so important even at the cellular level, okay? When you move on to advanced EMT, or if you come back and take the EMT IV class from us, you'll learn that the fluid that we give, right, which is normal saline, believe it or not, is not the best thing for people, right? In fact, in trauma, when we used to just give fluid and give fluid and give fluid, we've actually found that actually causes more damage than it does good, right? So we're really starting to look at even fluid therapy is not as important as we once thought, okay? Because you can really mess with clotting and the way your cells operate by just dumping fluid into them. Okay, glucose in the cell, okay, glucose is that building block, okay? Glucose is that one component your body has to have. What are the other two components to survive? What do you think? Oxygen is the second one. Fluid is the third one, right? Got to have sugar, got to have oxygen, you got to have fluid, okay? Anytime you're missing one of those, you're going to have problems, okay? Lack of oxygen, what do we call that? Hypoxia, right? Low sugar, what do we call that? Hypoglycemia, right? There's the flip side of that that's called what? Hyperglycemia, okay? So if hypoglycemia is lack of sugar, hyperglycemia would mean too much sugar, but what does that do? Why is that such a bad thing? Say again? So there's the insulin component. What else does it do to your body? Too much sugar. What happens to your body? Say again? So it does turn to fat. What else, though? Think more severe. Okay, so there's that. What else? Keep thinking even more. It makes your body acidic, right? So it changes your acid levels, and when you start messing with pH, your body has to find a way to dump that acid off, right? When we talk about diabetics, we're going to talk about the dangers of hypoglycemia because it kills you in a short amount of time. We'll also talk about the dangers of hyperglycemia because it can cause damage and death over days or weeks or possibly closer to a month. Okay, it messes more with the acid base than it does with starving of brain cells. So the two metabolisms, aerobic, meaning what? Has oxygen, right? Anaerobic is without oxygen. Okay? So with oxygen, everything works just like it's supposed to. Okay? You got oxygen, you got glucose, you produce ATP, your body's good to go. The second you start losing oxygen, your body now starts metabolizing just the sugars, right? And when you do just that, what starts getting produced? Lactic acid, which makes your body more acidic, okay? And I'm going to show you here in a second that when your body starts producing acid like it's not supposed to, it uses every system in your body to try to get rid of that. It tries to work on your respiratory system. It messes with your cardiovascular system. It messes with your kidneys. It messes with your liver. It starts messing with your renal system. It makes a big, big mess, okay? So one of the things that we can control, and this is why we used to give oxygen to everybody, is we always had this thought that oxygen never hurt people, okay? We just assumed that by giving them pure oxygen, you were just helping with aerobic metabolism at all times. Come to find out, we've been wrong this entire time about oxygen, okay? And next week we kick into airway and breathing and talk about the dangers of oxygen. This is just a visual look, right? So aerobic metabolism, you got oxygen, you got glucose that produces ATP. That's pretty straightforward. Here's the other side of no oxygen. It metabolizes that glucose and builds that acid. Okay? Does this produce some ATP? Yes, right? Just not enough. Okay? So if you see a test question, sometimes they're kind of tricky with the way they word that and say, yes, it's true. Both of them produce ATP, but this one produces much, much more acid than it does ATP. Okay? It doesn't produce enough ATP for your body to use it like it's meant to. Okay? So kind of keep that in mind. So this is kind of a look forward in the class. We're going to talk kind of about acid levels and EMS. Okay? One of the new tools that we brought down in out to the pre-hospital is what's called end-tidal CO2. You usually see it as EtCO2. Okay? We take this cord, and it attaches to our tubes, or so we have a nasal cannula one, and this attaches to the monitor, and it actually gives us a number that talks about CO2 in their exhaled air. Okay? I will tell you that normal end-tidal CO2 is about 35 to 45. Okay? And that's millimeters per mercury, measured the same way your blood pressure is. The nice thing is that if we're talking about end-tidal CO2, it always gives us the number on the monitor. Okay? So this is normal. When a person is in cardiac arrest, and if you're doing just chest compressions, and your chest compressions are at a rate of 100, and it's a depth of 2 inches, and your chest recoil comes back to 0, you produce an end-tidal CO2 of about 10 to 15. Okay? So what we've found out with end-tidal CO2 is because of the way that anaerobic metabolism works, we can actually, with end-tidal CO2, we can actually find out that you're breathing or have a pulse on your own faster. okay? Before, every 2 minutes you check for a pulse, right? At some point during that 2 minutes, you could have got a pulse back, but we wouldn't know because we don't check for a pulse except for every 2 minutes. Now with continuous EtCO2 monitoring, what will happen is this number will be at 10 or at 35 or 45, and all of a sudden, because of washout, right? If your blood is stagnant, anaerobic metabolism kicks in, and it just produces a bunch of acid, right? But if your blood's not moving in your outer extremities, then it's just going to sit there, okay? When your heart starts beating like it's supposed to, it circulates that CO2 or circulates that acid into your respiratory system. And you start what's called washout. You start blowing off CO2. So this number spikes to 60, 70, 80, or 90, right? Anywhere on there. All of a sudden, your CO2 will just jump through the roof, and you check a pulse, and they have a pulse. We can pick up on return of spontaneous circulation faster when we use end-tidal CO2s, right? All it takes is monitoring that CO2, and you find out that your body's circulating like it's supposed to. Does that make sense? So that's one of the tools. Let's talk about crush injuries. What are the dangers with crush injuries? So let's say you got a guy in the woods who log falls and has pinned him mid-femur, right? No pulse. The leg is cold. He can't feel his toes. So complete and total blood circulation has been cut off. Okay? What's the only way to get him to the hospital? You got to take the log off, right? Are there any dangers with that? So there's lots of blood. What else? Clots. What else? There's one more component to that. Lots of blood and clots. What else? What's happened downstream from that? In that area that's not circulating, what's happened? It's stagnant, right? So your muscle fibers break down and produce acid, right? You've already converted to anaerobic metabolism. It's created acid, so it's just sitting there. You lift the log, what happens? Circulates all that acid to your heart, right? How fast do you think that kills you? Pretty quickly, right? So one of the things we've talked about is you've got to kind of make a decision. Are you going to wait for a paramedic to get there? Because a paramedic can give some drugs to preemptively counteract that acid imbalance. Okay? We give them a drug that opens up their breathing tubes, and they give them a drug that protects their heart from all that acid. Okay? Then you can lift the object. What do you think another option is? How does it work? Put it above the object, crank that sucker down, prevent the blood flow, lift the object, drive to ALS or drive to a hospital. Okay? Think about that stuff ahead of time. That's the stuff that doesn't get thought about in the field. During the windstorm, I had the wonderful opportunity to work on the Wednesday after this most recent big windstorm. And they had a guy in one of the trailer parks that a tree had came down and landed on top of him and cut his circulation off to his leg, right? Extrication, rescue, all that stuff. He was trapped under that tree probably close to 2.5 to 3 hours, right? Thankfully, the paramedic before, they were getting ready to lift the object, and somebody on scene said, do you think we should initiate crush protocols? And the paramedic said, that's a really good idea, right? Saved his life, guaranteed. Hospital was like, if you would have lifted that, it'd have killed him, right? 10, 15 minutes into that call, he'd have gone to cardiac arrest and he'd have died, right? But if you do it preemptively, problem solved. Now, the paramedics on scene, that's easy. If they're not or you don't have that option, think about that tourniquet, prevent that blood flow from going back to the heart, and then transport them. Okay?
Well, how long do they have to be stuck?
35 to 45 minutes, you should be starting to think about it, right? It's taken about that long. If you think about your brain and your heart and some of your vital organs take a couple of minutes before they die from lack of oxygen, your muscles do a pretty darn good job of waiting. So that 30 minutes, that'd be like my red flag. 30 minutes, would be like, yeah, let's maybe think about their crush protocols. Really good question. So vulnerability of cells, organs, and organ systems. We kind of talked about how those all work together. Diseases can alter that permeability. What does permeability mean? Yeah, so it's just kind of how things flow in and out of a lining, right, or in and out of a cell, something along those lines. If you have ineffective cell membranes, it doesn't allow substances into the cell, or it does allow things into the cell that shouldn't be there, and it can interfere with allowing things out. Okay? So let's look at the heart and the respiratory system. This is where it gets pretty brutal. Okay, so they do work together. We talked about that, right? Blood goes round and round, air goes in and out. Okay? The purpose is you gain oxygen and you remove waste products from the body. Now, the reason why blood goes round and round is because you have to get it out to all of your body, okay? And the only way in and out is through your respiratory system. So if you have a circulatory system and no respiratory system, then what do you keep a lot of? If you're not breathing but your heart is beating, what does your body have a lot of? Waste. That's CO2, right? And if you're breathing but it's not circulating, then the rest of your body's not getting oxygen, okay? That's why in this class we'll talk about hands-only CPR, but we still encourage that you provide oxygen in some way, shape, or form to cardiac arrest patients, okay? We'll talk about variations. We've kind of changed some things here in Spokane County, but we'll talk about that. But hands-only CPR is great if you don't have enough rescuers, or if you are a lay person on the street, or a professional rescue without a barrier device, okay? Other than that, most times we're providing oxygen. We're going to talk about a little more on airway next week as we break into chapter 9 and 10, but airway is where it starts, right? If you don't have an open airway, then there's no way to get oxygen in and out. Does that make sense? So the term you're going to get used to is what's called patent, okay? Patent means it's open and it will stay open, okay? A non-patent airway is something you have to fix. Okay? We've got subtle things like head tilt chin lift or jaw thrust maneuvers, which we'll talk about, or a little more aggressive with oral pharyngeal airways or nasal pharyngeal airways. And then the most aggressive we give you is that King Air or that combi tube, which is a little more invasive when it comes to airway control. Tuesday next week, we'll get a chance to learn about it. Thursday next week, we're going to get a chance to actually play with it. Okay? So patent is the word you're looking for. Okay? Patent means you're good to go. Okay? So when you take a nice big deep breath in, goes through your mouth and nose, right past your epiglottis into your trachea, okay? Your trachea goes down and it splits, okay? And we know what that split is called. There's a name for it. We know? Carina. If you see it on a test, not on, maybe on section 2, for sure on section 3, right? There's an arrow right here in the middle called carina, okay? It splits. You got the left mainstream and the right mainstream. Again, remember, not your right and left, it's their right and left. Okay? So right and left mainstream, then it breaks up into the secondary bronchus. Okay? See what this is the mainstream and then this is the secondary. And then you have tertiary, which are these smaller ones, and then you have bronchioles. Anytime you add O-L-E, that means a smaller version of. Okay? Arterial, bronchial, all means smaller versions, right? Just like a street, an arterial is a smaller version of a road, okay? Less traveled, slower speeds. Make sense? So you go all the way down to the bronchioles. At the end of the bronchioles are the alveoli, okay? The alveoli, we have called these like the tiny grape-like sacs forever, right? This is where everything happens, okay? Surrounding those grape-like sacs is capillaries. Okay? This is where the intersection happens between oxygen and blood. Okay? This is where your airway and your cardiovascular system meet. Okay? When you take a big, nice, deep breath, okay, your alveoli open or expand. They got these elastin fibers that allow them to get bigger, and the lining of your alveoli touch your capillaries. Okay? Then that's where oxygen flows into your bloodstream and CO2 comes out of your bloodstream. When you exhale, those elastin fibers contract, and it causes that positive pressure and pushes everything out. Does that make sense? Pretty easy, no big deal. Okay? Here's the annoying person. I think this time it's a lady to talk about that exact process, except for I didn't plug in the sound.
The mouth or nose, and quickly moves to the pharynx or throat. From there, the air passes through the larynx or voice box and enters the trachea. The trachea is a strong tube that contains rings of cartilage that prevent it from collapsing. Within the lungs, the trachea branches into a left and right bronchus, which further divide into smaller and smaller branches called bronchioles. The smallest bronchioles end in tiny air sacs called alveoli, which inflate during inhalation and deflate during exhalation. Gas exchange is the delivery of oxygen from the lungs to the bloodstream and the elimination of carbon dioxide from the bloodstream to the lungs. It occurs in the lungs between the alveoli and a network of tiny blood vessels called capillaries, which are located in the walls of the alveoli. Here, you see red blood cells traveling through the capillaries. The walls of the alveoli actually share a membrane with the capillaries. That's how close they are. This makes it possible for oxygen and carbon dioxide to diffuse or move freely between the respiratory system and the bloodstream. Oxygen molecules attach to red blood cells, which travel back to the heart. At the same time, the carbon dioxide molecules in the alveoli are blown out of the body with the next exhalation. Gas exchange allows the body to replenish the oxygen and eliminate the carbon dioxide, both of which are necessary for survival.
The music is so motivating.
The broadcast is now starting. All attendants are in listen-only mode.
Great. All right. So we talked about the open airway, right? That's where the whole process starts. So your airway is broke up into two pieces, upper airway and lower airway, okay? Upper airway is from everything from the glottic opening up, okay? Your mouth, your nose, the back of your throat, your tongue, all of that is an upper airway, okay? Everything from your glottic opening, right, where your epiglottis is, everything lower than that is considered to be lower airway, okay? It's important we start talking about airway sounds that you know the difference in upper airway and lower airway, right? Snoring is an upper airway sound. What is that noise? Why does it keep doing it? It's really annoying. Okay, so upper airway would be snoring, right? Lower airway would be like a wheeze or some sort of constriction in the bronchioles. Okay, so upper airway obstructions are common. Foreign bodies, food, marbles, matchbox cars, all kinds of things kids put in their mouth. Okay, infection or trauma are also pretty common. What is the most common airway obstruction? Try again. There you go, your tongue, right? Number one airway obstruction. Now, everyone always kind of gets confused. So what is it really caused by? Okay? What's that? So no, because it's not swelling at your tongue. Okay? You're close, though. If you lay flat on your back when you sleep, does your tongue obstruct your airway? That's when you snore, right? Maybe. But not normally. Okay? If you're unconscious, you lose your ability to control that muscle that controls your tongue. Okay? So what happens then is that muscle relaxes, and it actually slides back and obstructs your airway. Okay? All unconscious people need some sort of airway control. That's why we talked about all unconscious people without spinal injuries go in the recovery position. Because the recovery position eliminates that tongue from sliding back and opening your mouth. Does that make sense? You lie flat on your back, they're not going to breathe very well. So lower airway, shocking, your lungs are in that. Okay? So tidal volume is the volume of air moving in and out during each breath. Okay? It's measured in milliliters, and the average tidal volume is 500 mLs. If you want to be real specific and be a respiratory therapist, you can say, on average, 7.5 mLs per kilogram is tidal volume. Okay? So you could take someone's weight and figure out how much that's kilograms, and then figure out 7.5 mLs per kilogram and find out what their normal tidal volume should be based on weight. By the end of this class, you'll understand that 500 is a good enough number. Okay? Make it simple. So 500 is normal. Okay? Minute volume is how much in mLs that person is breathing in and out in 1 minute. So the way you figure that out is you take your tidal volume, you take your respiratory rate, and you multiply them, and that equals minute volume. You may see that on your next test. Okay? Real basic math problem. I will tell you, because we don't allow calculators, it's very obvious. Usually it's like, is the answer 1,000, is the answer 100, or is the answer 350? They're not going to be like, is it 1,000, is it 1,001, is it 1,002, or is it 1,003? Okay, they give you 4 very, very different answers. Okay, normal tidal volume, 500. Normal respiratory rate for adults ranges anywhere from 12 to 20. Okay, so on the NREMT, they almost always give you the respiratory rate, okay, because it has a range. If they don't give you a tidal volume and want you to figure out minute volume, then just use 500. Make sense? Pretty easy. So I thought we talked about it. I don't know where it's at. So one of the things we're going to talk about is dead space. Does your textbook talk about dead space? What's normal dead space for an adult? What's that? 150, 150, right? So what is dead space? Yeah, it's basically, I always think of it as the distance from your nose to your alveoli, right? Everything above your alveoli that you breathe in never touches your alveoli. So if you take a big, nice, deep breath of 500 mLs, only about 350 of those mLs actually participate in that gas exchange. Okay? 150 mLs is totally worthless. So here's the scary part. Let's say you have a respiratory problem like anaphylaxis. Okay? Your throat's starting to swell. Your tidal volume drops. Okay? So your tidal volume drops to 300 mLs. So now you're only getting 300 mLs into your body. Okay? How much of that is reaching your alveoli? Only half, because dead space never changes. It can't, because you never change the distance between your nose and your alveoli. So volume, how much you breathe in, is very, very important. If it's shallow, you're not getting enough oxygen. Does that make sense? So any change in tidal volume or respiratory rate reduces your minute volume. Okay? If you're breathing too slow, you're not getting as much oxygen as your body's used to. If you're breathing not deep enough, you're not getting enough oxygen your body is used to. Okay? Next week on, I think it's on Thursday, the topic we're going to talk about the most is respiratory dysfunction. Okay? By the end of Thursday, you'll know the difference between an adequate respiratory rate or adequate respiratory system and an inadequate respiratory system. Remember way back on day 1, that was the very first thing that said by the end of this class you should know the difference between adequate versus inadequate. That's the big one. Respiratory distress versus respiratory failure. Okay? Disruption of respiratory control, okay, the powerhouse of you breathing is controlled medulla oblongata, which is found where? Your brain. Okay? Where on your brain does that sit? The back, where we're talking about the stem, right? So head injuries, can it mess with your breathing? Absolutely. Okay? Meningitis can mess with your breathing. The other one, we'll talk about opiate-based drugs. Okay? Heroines, anything that has opium is going to mess with your medulla oblongata. Okay? One of the reasons why we're bringing naloxone or Narcan to the EMT level is because we've seen an increase in opiate uses throughout the country. Okay? So much so, we're talking about putting Narcan in cop cars so cops can give it. Okay? There are programs that have put it in college dormitories for students to give fellow students who are overdosing on opiate-based drugs. Article popped today to put it in elementary schools. Right? I will tell you, when Jay comes here, he'll talk about drug use here in Spokane. If you think Spokane is still the meth capital of the country, you are horribly wrong. There's very, very little meth in this city. Right? And what is there is extremely expensive. You know what we see on a weekly basis? Heroin. Right? Heroin has made a violent comeback into the city and the county areas. Right? We don't see a lot of methamphetamine, we see a lot of heroin. which is good because the meth overdoses, we can't really do anything for you, right? The heroin overdoses, naloxone or Narcan saves your life. Okay, that's what the only perk of let's sell heroin instead of meth. Not that I participate in that, I'm just saying one is better than the other. Okay, disruption of pressure. So we talked about your respiratory system being based on pressure. When you inhale, what type of pressure is that? Negative. When you exhale, it's positive, right? So in order for that to happen is you have to have an enclosed vault, okay? You can't have a giant gaping hole in your chest and expect those pressures to work like they're supposed to, okay? So you have to have your chest wall with your ribs and all that protection and make sure that there's nothing that's pushing on that space. Your chest cavity is called the pleural space, okay? So if there's air in the pleural space, we're talking about a pneumothorax. If there's blood in that pleural space, we're talking about a hemothorax. And in unique circumstances, you have them combined called a hemopneumothorax, okay? You can have what's called a spontaneous pneumothorax, where spontaneously your lung pops or has a spot on it that explodes basically and your lung collapses, okay? It's very, very rare you have a spontaneous hemothorax. Usually the hemo involves trauma or penetration or something along those lines, guns, knives, steering wheels, that kind of stuff. You can have a traumatic pneumothorax. That's easy to see because you're looking at a bullet hole, you're looking at a stab wound or whatever. The spontaneous pneumos are kind of the scary ones, okay? Statistically, young, Caucasian, tall, skinny males are the big red flags, right? 17-year-old kid, 6'6", who weighs 110 pounds, running at a track meet, who blows a lung, right? Complains of chest pain, complains of shortness of breath. You're looking at this kid going, you're healthy, you're athletic. I don't know what's wrong with you. You listen to his lungs, and he's not having any air movement in one whole side of his chest, right? That's the stereotypical presentation of a spontaneous pneumo. We talked about trauma. Obviously, if you're messing with the lung tissue itself, right, if you're not perfusing the lung tissue, on Thursday we'll take one of those pig lungs and we'll cut it in half, and you can actually see the blood vessels that feed the tissue itself, right? Less oxygen gets in, therefore less carbon dioxide gets out. If you put a blood clot in that lung tissue dies, okay? We call those pulmonary embolisms. Okay, we're going to talk a lot about embolisms, but pulmonary embolisms, or PEs, are extremely life-threatening. Okay? We talked about hypoxia being low oxygen levels. What's hypercapnia? High CO2, right? I would tell you, you'll see this used interchangeably. Sometimes the textbook says hypercapnia. Sometimes they call it hypercarbia. Okay? Carbia or capnia are carbon dioxide. Okay? So the way your body is used to breathing, it has these chemoreceptors, okay, throughout your body that basically pick up on levels that tells you to either breathe more or breathe less, okay? You right now normally, all of you, are breathing based on what level? What do you think? 50-50. Take a wild guess. Carbon dioxide. Okay? Your body breathes based on carbon dioxide levels. Okay? If your carbon dioxide level goes up, we breathe faster. Your carbon dioxide level goes down, we breathe slower. Okay? That's us normally. Now the weird one is our chronic obstructive pulmonary disease patients, COPD. Okay? They have what's called a hypoxic drive, which means they are always retaining CO2. Okay, because of the pathophysiology of COPD, they retain CO2 at all times. So their CO2 levels are always higher. Okay, so their body has actually flipped and breathes based on oxygen levels. Okay, and I will tell you that normally their oxygen levels sit at like 90 to 92%. Okay, that's normal for them. Normally for us, we'd consider that to be mild hypoxia. Okay, that's normal. The original danger of oxygen, we were telling EMT students, is if you give pure oxygen to a COPD patient, that you'll kill them, right? Because what happens is pure oxygen, right? Right now you're breathing how much oxygen in the air? 21%. A non-rebreather of oxygen gives about 80 to 90% oxygen. Some textbooks say 100%. Okay? So what does that do to the saturations of 91 or 92%? What does that do for them? Pushes them to 100%. Okay? So their body is looking at, their chemoreceptors are looking at 100% oxygen for 10, 20, 30, 45, 50 an hour, right? And their body says, my oxygen levels are perfect. What does their body do? Stops breathing, right? Pure oxygen literally made them quit breathing. So we used to have nurses who would freak out when we walk into an ER with patients with non-air breathers. And they go, you're going to kill them. First off, it takes a long period of time. And second off, if they are having respiratory problems, you're still going to give them oxygen. Okay? Oxygen has turned into what's called a titrate to effect drug, which means only use it to gain what you're looking for and then either take it away or decrease the amount you're giving. Okay? You walk in the door and the person's breathing, 25 times a minute and their saturations are 85%, give them a non-air breather. Their saturations go to 95%, take the non-air breather off and give them a nasal cannula instead and see if they maintain oxygen saturations where they're supposed to. Does that make sense? It's not just a give the drug, give the drug, give the drug all the time. We're now looking at give the drug, wait 5 minutes, reassess. Is it working? Great. Let's see if we can take it away. Or at least step down how much we're giving. Okay, so the blood piece of that, that's all the oxygen piece, right? Not that it's important. The blood itself, we talked about plasma, right? That's the liquid. We're going to talk about proteins in the plasma here in a second. Red blood cells are the oxygen carrying capable for the hemoglobin piece, right? Without red blood cells, you don't get oxygen throughout your body. Okay, they work together. White blood cells are meant to fight infection, and we talked about the way platelets work to form clots, right? Sometimes this is a good thing, sometimes this is a bad thing. Okay? SpO2, right, or oxygen saturation is a device that, if you guys on the fire service know it, goes in the finger. If you've seen it on TV, it's the little thing they clip on your finger, right? And it gives you a number, right? I'm going to go back just for a second. It's right there. Okay? So you'll usually say this SpO2 percentage, right? So what an SpO2 does is it takes one hemoglobin with a UV light and shines through that hemoglobin and says it's X amount percent of oxygen. Okay? We used to tell EMT students all your patients should be 100%. It was the biggest lie we ever told. Okay? You belong 94 to 96%. Okay, that's our goal for you. Okay? If you ever smoked, if your rate is a little bit low or whatever, 100% is pretty rare. Okay, we see 98s, we see 99s. For the most part, again, that goal is 94 to 96%. Okay? The only thing that does is it looks at one hemoglobin. Okay? So one hemoglobin says you are 99% oxygenated, which to us means you're perfect. Right? The downfall is when are the times that you can think of where that would be misleading? So CO poisoning, right? CO has the same transparency to light as oxygen. And CO binds to your hemoglobin 2 to 3 times better than oxygen. Okay? So you run your car in your garage with the door open into your living room. You run a generator into your house. You run, something catches on fire and burns, okay, and produces CO, right, carbon monoxide. So we put that SpO2 in your finger, and it says you're 99%, totally inaccurate, right? If it's cold outside and you have poor perfusion to your fingers, then you're going to get an inaccurate reading, okay, because you're not circulating blood like you're supposed to. The other one is always in shock, this lies to you, okay? It looks at one hemoglobin, which means if you only have one red blood cell in your entire body, would you die? What do you think? Yes. But what is your SpO2 going to say? You're good to go, right? So people who are bleeding, this doesn't give you an accurate description because you might be losing red blood cells, but the ones that you do have are still carrying oxygen perfectly like you're supposed to, okay? So always think SpO2 is a really, really good tool, but never let that thing fool you, okay? It's a computer. It's a device. Treat your patient, not your equipment, okay? I've been on patients who are conscious and alert and talking, who are warm, pink, and dry, and you put the SpO2 on, and it says they're 72%. And people freak out. And you're like, they're conscious, alert, and talking. They're warm, pink, and dry. They're not complaining of anything. There's something wrong with it. Or vice versa. They're blue. They're barely breathing, right? They're unconscious. Their heart rate's 4, and SpO2 says 100%. Doesn't matter. I'm still going to breathe for you. Okay? Don't let that thing fool you. So here's the two terms that students absolutely hate. Okay? Plasma oncotic pressure and hydrostatic pressure. Okay? Associate it. Plasma oncotic pressure pulls. Hydrostatic pressure pushes. Okay? So plasma oncotic pressure, there's proteins in the plasma, usually large proteins, that attract water away from around the cells and they pull it into the bloodstream. Okay? Now the flip side of that is the hydrostatic side. Water's pushed back out of the blood vessels towards the cells. This is where your cells maintain that hydration at all times. Okay? Patients that are liver failure patients, what happens is their liver doesn't produce this large protein. Okay? So what happens then is fluid will just flow out of your vessels out into the muscle space, which causes edema, which is fluid in your muscles. Okay? That's not a good thing. We're going to talk about fluid here in just a second of transferring out into those spaces, but it's not a good thing. Okay? Know those two terms and have a really good idea. Just know it's that maintained balance of hydration. Okay? If it's not pushing or pulling like it's supposed to, you're going to have fluid that's flowing out into spaces it doesn't belong in. I'm going to show you the balance between fluids here in just a second. It's going to break down how much fluid is supposed to be in your vessels, how much fluid is supposed to be in your cells, and how much fluid is supposed to be in the interstitial space, which is that space where your muscles sit. Everybody got those two? We good? Still awake? You tracking? Cool. So the most common blood dysfunction relates to volume. Okay, whenever we deal with blood, the most common time we have a problem is when they're losing it somewhere. Okay, bleeding is one of the most common blood dysfunctions you're going to deal with. Now, external bleeding is easy. Okay, if there's a hole, plug it. If it's cut off, fix it. Okay, and external bleeding you can see. Now, the internal side is a little misleading because you can bleed out into cavities of your body and we never know it's there. Okay? So external is the easy one. Internal bleeding is the more difficult one. When we get into shock and trauma in a couple of weeks, we'll talk about that a little more in depth. So we talked about your body needing blood. It's got to have oxygen. It's got to have that sugar, right? The small piece of that with oxygen, think of it's got to get rid of CO2 and it's got to gain oxygen. You have to have those components. Make sense? You still good? No, I stopped listening an hour ago. Only been in class for 50 minutes. All right, so the one on the left is a artery, okay? It always carries blood away from the heart, okay? 99.9% of the time, that blood is oxygenated, okay? When's the one exception? Pulmonary arteries, okay? Veins always travel towards the heart, and 99.9% of the time are deoxygenated, which is why we've always shown it as red and blue, okay? Is your blood actually blue without oxygen? No, right? It's my favorite thing to convince my brother, who's like 22 years old. Still to this day, he is researching, finding out why blood is blue, because I have him convinced it looks just like this. Right? It's fun, right? It's a good time. What other distinguishing factors does this have that this doesn't? Anybody know? Say again? Valves. What's the purpose of them? Yeah, it doesn't let blood backflow. Okay? When we start IVs as either EMT IVs or advanced EMTs or paramedics, which one are you accessing? Veins, because we don't want to stick needles in these. Okay? It makes a lot of mess. Okay? I've done it once in my career, real bad decision. Okay? So the problem with this is valves are not something that are anatomically in positions. Right? You can have people real valvy. You can have valves just in the middle of the vein. And I will tell you, we stick a needle in your vein, and we bump into a valve, and we drive that needle through your valve are the times that you get those wonderfully shooting pains up and down your arms, right? It's extremely painful, okay? So a lot of times what we'll do is we'll try to run fluid to get that valve to open and then slide that catheter past that open valve, okay? That's our attempt. Sometimes it works, sometimes it doesn't. Okay, blood vessels. We talked about taking that oxygenated blood from the lungs into the heart, right? We talked about the capillaries. So the downfall, when oxygenated blood comes from the lungs, which side of the heart does it enter? The left side, right? So let's say you have what's called left-sided heart failure. So the left side of your heart just doesn't pump hard enough to get rid of all of the blood out of your heart. When it backs up through the ventricles, through that atria, and it ends up back out into your lungs, right? Does that make sense? If you have right-sided heart failure, okay, right side, it backs up in the right ventricle and backs up in the right atria. Where does it have to go? Say again? Back to the body, right? Right-sided heart failure produces pedal edema, right, or edema in your feet, okay, because that's back out to the body. Left-sided heart failure puts fluid back into your lungs, and you get what's called pulmonary edema, which is fluid in your lungs. Make sense? Associate those. Left in lungs, and the other one is body. I don't have an association for right, sorry. But left is lungs. Left-sided heart failure produces pulmonary edema. Okay? So what happens then is fluid backs up into your lungs, okay, and your lungs start to fill full of fluid. Okay? So if you put a bunch of water in your lungs, are you able to exchange gases at the alveolar level? No, right? Because air gets trapped and it just sits there. Okay? So one of the things that we have recently given EMTs is what's called CPAP. Okay? CPAP stands for Continuous Positive Airway Pressure. Now, most of you probably heard about CPAP if you have parents or you yourself are a snorer and have sleep apnea, right? Because we've even pushed this out to the public and said, hey, this can fix sleep apnea. We use it a little more aggressively than sleep apnea, okay? So if your lungs fill full of fluid, the only place that you could push that fluid is real hard down in the alveoli, and if you push water into alveoli, it makes your alveoli expand, right? And if they expand, they touch the capillaries, and you start shoving that fluid into the cardiovascular system, right? Because that's the capillaries. Then that allows your heart to pump it out like it's supposed to. So that's what CPAP does for us. It forces air into the alveoli to make sure they stay open, to always allow blood to circulate. Okay? The two definitions I want you to write down. CHF stands for congestive heart failure. Okay? CPAP stands for continuous positive airway pressure. Okay? Now, here's the scary part about CPAP. Most of these patients are complaining of basically drowning, right? They got all this fluid building up in their lungs. They don't like to lay flat. They feel like they're drowning. They feel like they got this heavy weight on their chest, okay? Then you're going to apply CPAP. And I will tell you, we've always talked about CPAP of being the equivalent because it's positive pressure. How many of you are firefighters or ever been scuba diving, right? That's not continuous pressure, right? When you breathe and change the pressure, it gives you oxygen. This is a nonstop flow of oxygen at a pretty high pressure in your face, okay? How many of you ever driven down the road and sticking your head out the window? Anybody? What's the first thing you can't do? Breathe, right? Because you're pushing positive pressure into your face, which your body's not used to, okay? So we take these people who feel like they're drowning, who feel like they're suffocating, and you stick that CPAP in their face that makes you feel like you can't breathe. So there's this period of 2 to 3 minutes where you're talking them out of anxiety and being like, you gotta let this work. There's a secret to CPAP, okay? If you're driving down the road and you stick your own head out the window at 90 miles an hour, you are in control, right? So that would lower your anxiety level, okay? If I grab you by the back of your head and hold your head out the window, that adds anxiety, right? Do not ever hold the CPAP mask on their face, okay? Let them hang on to it. Because if they start to freak out, they just pull the mask off, okay? You talk to them and say, you got to put the mask back on. I understand you're scared, but this is going to help you. Okay, I will tell you, since the introduction of CPAP, we've seen decrease in intubation rates in patients almost 50% throughout the country, right? This is fixing the problem instead of the paramedic having to take away their airway, okay? So this video is to kind of show you what CPAP does and how it works. These are rabbit lungs, and they were placed in a glass case to reproduce like the pressure that's in your chest, okay? So, hopefully it plays. Play, please. Perfect. So, they took a BVM, okay, and they've bagged just these rabbit lungs, no CPAP, okay? Now, notice how nice and pink colored this is right here. Does that make sense? That's good perfusion, right? Pink is good, okay? Notice the color as you start to work your way up of how red this looks, and then you got these areas where you're getting no perfusion whatsoever, okay? Think of that as fluid-filled alveoli. There's so much pressure on the alveoli, or it's filled so much full of air, the alveoli can't open and gain oxygen, right? This is dead tissue. Mind you, these are rabbit lungs taken out of rabbit, clearly, right, that have been dead for who knows how long, okay? So he bags it once more with just no CPAP, okay? Now he's going to turn CPAP on to a low level, okay? Watch the difference. It's right here. Notice how the lungs don't deflate, okay? So he just bumped CPAP to like a 2. Stop, okay? Basically, all it did is when you breathe in, your alveoli open, and when you exhale, your alveoli close, okay? By adding CPAP, you don't allow your alveoli to close. Low levels of CPAP, let's say you add just a little bit of pressure, your alveoli get close, but they don't close all the way. Notice how now you have pinker tissue, okay? You still got areas where there's no perfusion, okay? Because we're still at low levels of CPAP. They continuously add some more pressure, okay? Notice how, again, the lungs don't completely deflate. And there's one more time after this. Look at the color, right? That's good tissue. When we mess with the pig lungs, we'll actually attach a BVM to the pig lungs and the trachea, and we'll inflate that lung, and you'll see this feels like a Tempur-Pedic mattress, right? It's like nice and fluffy, and you almost want to lay on it, except for it's a dead, rotting pig carcass, and you don't want to actually do that, right? But you'll inflate it, and you'll feel the difference. Now I want you to watch. They turn the CPAP off and go back to just one normal breath, okay? This is perfect perfused tissue. Is it moving? I don't think it's moving. There, we're moving. Okay? So what they're trying to show you is, let's say the person breaks the seal, okay, or you turn it off, one breath, you're back to dead tissue. That's how important CPAP is, okay? So we use this on patients that are having pulmonary edema, right, your CHF patients who are drowning, your patients who are COPD that have constricted bronchioles or a lot of mucus buildup down in the alveoli that doesn't work. And in Idaho and some other states, they can actually do this for drowning, right? Patients who are actually submerged in the water, who you have no way of getting the fluid out of their lungs, but you can push it into your cardiovascular system and get it out of your body using your heart, right? Because your heart then pumps blood, and then your kidneys filter that blood, and then you're just peeing out the waste, right? So, like I said, this was one of the big things, and I will tell you, you guys are only about a year into this. A year ago, EMTs couldn't touch CPAP, right? You couldn't use it. Don't even think about it. Now we're like, it's a great tool. There is some things you got to be worried about, but let's give it to EMTs. So it's one of the things that we'll talk about with respiratory. Does that make sense? Cool. Let's take a quick break. Stand up, stretch, get some coffee. Let's keep going, shall we? All right, so you got pressure's the biggest piece of this. We talked about it with the negative and positive with the respiratory system. Cardiovascular side's the same way, okay? Pressure is based on a couple of things. One, you have to have an adequate pump, right, which is your heart. You have to have proper pipe size, and you have to have the adequate amount of fluid, okay? A second ago, I just told you the most common dysfunction is the fluid, right? The most common time we deal with problems is when there's not enough fluid to go throughout the entire body, okay? with that, these stretch receptors monitor your pressure and change based on that, right? If your heart is pumping really, really hard, your vessels want to get a little bit bigger to take the workload off of your heart, okay? Remember the plumbing system? You got the pump, you got the pipes, and you got the fluid. Your pipes try to work to help your heart. If your heart pumps real hard, your pipes get a little bit bigger, okay? If your heart is pumping real slow and not a lot of fluid, then your pipes will get smaller to maintain and kind of pick up that slack. Does that make sense? Okay? So, depending on the situation, your pressure can either increase or decrease. Okay? When you get a little farther in EMS, advanced EMT and paramedic, you'll find there's even drugs that you can give that will mess with how much your heart can pump. Okay? There's drugs that specifically work on making your heart pump harder or making your heart pump softer. Okay, one of the things that happens is damage happens to those stress receptors, or a neurological problem causes your vessels to vasodilate. What does vasodilate? Get bigger. Dilate means bigger, constrict means smaller. Okay, so they lose that ability. Okay, your stretch receptors are directly linked to your spinal cord, right? Through a couple of different pathways, but just think of your spinal cord. Those nerve pathways are in control of your vessels, okay? So if you have a spinal cord injury that severs your spinal cord, from that point down, all of those vessels will just dilate and dump your blood pressure, okay? If that happens real, real low, maybe not as severe as if that happens at like C4 or C5, right? Way up high on your neck, you lose your body's ability to dilate or to constrict through your whole body, and you lose your blood pressure. Okay? So trauma can cause it, like we talked about. Infection, what do you think is the most common infection we see that causes loss of tone? You're close, because that's a neurological problem, right? Because we really see it in the neurological side. What else? Can anybody think of anything? Sepsis is the big one, right? Which is an infection of your blood that causes your vessels to become leaky. Okay? So fluid just leaks out of your vessels, and now you get infection that's spread through your entire body. Okay? You hear the word sepsis, think something life-threatening. I will tell you we have a couple of different codes or a couple of different things that we can call in the field to activate a specialized system. One of them is trauma. Okay? 20 minutes away from a hospital, we can call Sacred Heart and say, activate the trauma system, and there is a trauma team like you see on ER waiting for us. Doctors, nurses, 10, 15 people. We can activate a stroke in the field where there's a specialized team that's waiting for us. You can activate an MI or a heart attack, right? The other one is sepsis, okay? They are very, very aggressive in the hospital to treat sepsis because they can cause so much damage. And it doesn't just attack, you know, a heart attack's attacking just your heart. Stroke is just attacking your brain. Sepsis is attacking everything. It's body-wide. Kidneys, livers, spleens, brains, hearts, everything. It's just attacking everything it possibly can. Okay? Normal blood vessel, right? So imagine your stretch receptors as being in this like outer or this inner layer. Okay? If it's normal, this is normal blood pressure. Okay? This would be low blood volume, right? Because look how much space there's taken up by nothing. Remember how I talked about dissecting aneurysms? What I was talking about is the tear in this yellow lining that causes blood to then get forced past that and create that balloon. Does that make sense? So that excessive permeability, this is that sepsis, okay? This is a really, it's kind of childish and cartoonish, but this is a really, really good look the way sepsis works, okay? It basically eats away or causes damage so that it just flows out of that vessel. What's that? So we look at the infection side, right? You would have high blood or high body temperature. You would have low blood volume because blood's leaving your vessels. So you would present like shock with a chance of infection. And so we never diagnose in the field, and we'll talk a little more, but you can have a really darn good idea that it's sepsis, right? Temperature usually is 102, 103. We've seen 104, 105, 106, just depending on how high we're talking about, okay? This is the danger of appendicitis when it ruptures, okay? Your appendix ruptures, and then it just leaks all those contents out into your stomach, and your stomach gets an infection that works its way into your bloodstream, and then it goes from an isolated infection to an infection of your entire body, right? Now you have to get antibiotics on board and start working on cleaning that blood because it's just circling through your entire body. Okay, super dangerous stuff. What's the term hypertension mean? High blood pressure. Okay, so here's the link between chronic high blood pressure and a couple of different things. If you always have hypertension, always high blood pressure, you're messing with what's called SVR, your systemic vascular resistance. Okay? Just know the term. This is the pressure inside your vessels. If that's always high, you're always pushing on that inside layer. I'm going to go back for just a second. You're always pushing on this inside layer and always putting stress on your stretch receptors, right? Constantly. So the thing you run a risk for, the biggest ones is stroke and heart disease. Because the more damage that you do to those vessels, the more likely a clot is to cling to that inside layer. Once that clot sticks, platelets start building on top of that. It gets narrower and narrower and causes heart attacks and causes strokes. Right? These two are the same, except for one's in the brain and one's in the heart. Okay? Think of them as the exact same idea. A pulmonary embolism is really the same, only it occurs in your lungs. Does that make sense? So anytime you have a patient who's hypertensive, okay, again, high blood pressure, these things need to be on your radar as a possible thing that you're going to be dealing with. Heart attacks, strokes. Okay? Always kind of keep that stuff in the back of your mind. Every time your heart pumps, it pumps out about 70 mLs per contraction. Okay? So that's stroke volume, or SV. Okay? Not to be confused with SVR. Okay? So your normal cardiac output, okay, or stroke volume is about 70 mLs per contraction. Your heart squeezes, pumps out 70 mLs. The volume itself is based on three things with that pump. Okay? Your preload, which is the amount of blood that returns to the heart, the contractility, which is how hard your heart is squeezing, and the afterload, which is the pressure the heart has to pump against to force blood out into the system. Okay? So preload is the blood that's coming into the heart. Okay? Contractility is how hard those ventricles are squeezing. And afterload is that systemic vascular resistance, right? How much pressure is that heart pushing against? It takes all three of these and determines literally every, however often your heart pumps, all three of these to determine how hard to squeeze, right? Everyone always kind of discredits how much your heart actually does. Shocking, right? It's pretty important. No big deal. Okay, so we talked about stroke volume. We talked about the three components that have to do with stroke volume. Don't worry, there's more. We good on these three? Okay, you're good. Gives me time to drink my water. Good? Cool. Look, it's all in red. Don't you hate when that happens? So cardiac output, right? CO, this is kind of like minute volume, okay? You take the stroke volume, which is about, on average, how much? 70 mLs. And you take beats per minute, you multiply them, and you get cardiac output, okay? Again, this is a range. Average normal heart rate for an adult is 60 to 100. Anything less than 60 is called what? Bradycardia, right? Slow heart rate. Anything over 100 is called what? Tachycardia. Okay? So, again, if the NREMT asks you to multiply this, they have to give you the heart rate. Okay? Because it's a range. So if your heart rate slows down or the stroke volume goes down, then your cardiac output goes down. That makes sense? That one's easy. This is the one that if you think about it, is easy, but at first glance it's kind of awkward. If your heart rate goes up, especially excessively, your cardiac output's going to fall. Okay? If your heart is beating too fast and it never fills, it's never going to push enough blood out. Okay? Tachycardia is pretty common. Okay? Exercise, stress, heart rate of 110, 120, we're okay. Anything over 150 is considered to be a life-threatening problem. Because over a long period of time, that's going to cause dizziness and damage and can cause some pretty big issues. Right? We've seen heart rates as high as like 220 and 240. Right? Which means your heart's pumping as fast as it can, but you're not getting blood anywhere because it's firing long before that can even fill. Okay? Back. Don't yell at me. Back, please, now. Yeah, so paramedics have, scary things paramedics have, two sides of this. They got a drug that can fix it sometimes, and they have electricity that fixes this sometimes, right? The drugs is scary to the patient, but less painful than the electricity. The drug is called adenosine, and adenosine literally stops your heart for a period of time while you're still awake, right? So it's horrifying to a patient. Literally, you watch them on a heart monitor, and their heart beats, 220, 240. You give adenosine, and they'll just go flatline, right? And they're talking to you, and all of a sudden they just kind of go. And then adenosine has a very, very short half-life, usually seconds. So it's in your system, metabolized, and gone in a really short amount of time. In fact, if you don't get it fast enough, it actually doesn't even work before it even gets to your heart, and it gets to your heart really, really fast. So they try drugs usually first, right? Give a little adenosine, doesn't work. So the second time they double the dose of adenosine, right? After that, we start looking at electricity. Electricity is while you are awake, they usually give you a little bit of pain medication. They take a heart monitor and attempt to shock you out of this rhythm, right? And they start at low levels, and they just work their way up until either A, it doesn't work and you go into cardiac arrest, or B, it does work and you fix the problem, right? That's the downfall. If your heart rate's beating at like a heart rate of 220, your heart will go into that ventricular fibrillation and it'll just stop beating because your heart can't keep up with beating that fast. It all of a sudden just gets confused and just basically goes into that fibrillation mode and just quits beating altogether. So it's a pretty light, that's why I said anything over 150, you're calling for a paramedic anticipating something a little more serious. Okay? This is pretty childish, but it's a visual way of heart rate times stroke volume is cardiac output, right? How much are we talking, or how long are we talking about right here? In a minute, right? Minute volume is in how long? A minute. That was real shocking. Sorry, that was kind of confusing. Cardiac output's a minute, minute volume's a minute. Okay? So, we talked about having a pump problem, or a pipe problem, or a fluid problem. If you have a pump problem, it's only 3 possibilities. Okay, actually 2, but we're going to talk about the third. So, mechanical, right? Something's not allowing it to pump, or it's an electrical problem. Okay? I will tell you, you as an EMT in cardiac arrest circumstances, you hope it's an electrical problem, because that's the only thing that AED fixes. Okay? It doesn't even work on anything about mechanical. Okay? It only does with electricity. So on the mechanical side, it's the physical trauma. Okay? Can you get what is your heart basically? It's a large muscle. How many of you ever had a bruised muscle before? Most of us, right? Can you bruise your heart muscle? Easier than you think. When you have a bruised muscle, let's say in your arm or your leg, what don't you want to do with it? Move it around. So what do you think your heart doesn't want to do? Move around. So let's say you bruise your left ventricle. How much blood do you think you're circulating? Not very much. Okay? You can get struck in the chest with something and can cause a cardiac contusion, a bruise on your heart that leads to your heart to stop and you never broke a rib. Okay? That's how easy this really can happen. Okay? there's squeezing forces. Okay, we talked about your chest is in a cavity, right? If you fill that cavity full of air or fill that cavity full of blood, eventually it will start to squeeze on tissues. Okay? Your heart is surrounded by a sac. Okay? Inside that sac is about 10 to 15 mLs of blood at all times. Pretty little amount of blood. If you bruise that heart, it fills full of blood, and that sac squeezes your heart. Okay? We call that cardiac tamponade, which I've got in the word form right here in just a second. Okay? It literally squeezes your heart so it won't pump. Okay? That's the squeezing force we're talking about. And then there's the cell death, which is those coronary arteries that aren't getting enough oxygen to all of your heart, therefore leads to death of the tissue. Okay, electrical problems. This is all just pump problems, right? This is the plumbing problems. This is the electrical problems. Okay, for whatever reason, your SA node or your AV node or the Purkinje fibers or whatever are not doing what they're supposed to. Okay, there are some cases where your ventricles fire all on their own. Those Purkinje fibers just fire, 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 fire. You have to fix that with electricity. Okay, the only time you are shocking someone with an AED is if they are unconscious, unresponsive, and they are pulseless. Okay, do not hook an AED up to a conscious person. Okay, not a good plan. There is one rhythm, it's called ventricular tachycardia, that the AED will shock, but there's two types of VTach. One of them has a pulse and one of them doesn't. And so if your patient happens to be awake and in VTach, your AED will say shock advised. And nothing will get your patient more scared than that thing saying push to shock. Okay? One of the best pranks I've heard of in the fire service yet is they convinced a guy at District 9, a good buddy of mine, that AEDs were like tasers in law enforcement. That in order to use the AED, you had to be shocked by one. Okay? He literally let them get to the point where the pads were on. The AED was analyzing before he said, I don't think this is a good idea. Right? And they were like, you're right. We're not actually going to shock you. It's the greatest thing I think everyone has ever thought of. I think it's great. It's like asking a new person to go find the size 7.5 fallopian tube and see how long it takes them to find it. Yeah, all the time. Fallopian tube, blinker fluid, all those things are pretty common. Yeah, stir the tender, take the keys out of the engine, the usual. So we talked about the VQ match. I don't know what day that was. That Saturday or Thursday? I don't know. We talked about VQ match, right? Perfusion and ventilation. Okay? So these two work together that are always maintaining that balance between oxygen and blood. Okay? It's pretty rare these are like perfect, which is why your heart rate changes a little bit, your respiratory rate changes a little bit. If you lose one side of this, obviously it's most likely going to cause a life-threatening problem. Okay? That's pretty straightforward, pretty easy stuff. All right, let's talk about shock. This one's my favorite topic of all. So you get the most of the red in this point. So you should already have written this down once, right? Perfusion, which is defined as adequate delivery of oxygen and nutrients to cells and removal of waste products. Hypoperfusion would be low perfusion, which is a breakdown, which is the life-threatening or the inadequate delivery of oxygen and nutrients to cells and removal of waste products. Does that make sense? So perfusion is the good one. Hypoperfusion is the bad one. Okay? We don't really talk about hyperperfusion ever. You'll hear hypo and you'll hear perfusion. We don't talk about hyperperfusion. Okay? So shock, you'll either, the NREMT or my test will say shock or it will say hypoperfusion. They use them interchangeably. Okay, so no, they're the same thing. Perfusion's the good stuff, hypoperfusion's the bad stuff, or shock. What does every single person die from in the entire world? Shock. What's the purpose of your job? Treat and prevent shock. Okay, which is real easy because you give oxygen, you keep them warm, you give them fluids if you can, and you drive as fast as you can to a hospital. That's it. Okay, even at the paramedic level, that's their treatment. There's no magic drug to reverse shock, sadly. We give them fluid and try to make them live a little bit longer, but that's all we do. We go with this too? These two? This too? More coffee. So 4 categories of shock. Okay, write hypovolemic, give yourself a little bit of space, and write down hemorrhagic and non-hemorrhagic. Write down distributive, give yourself a little bit of space. Write down cardiogenic, give yourself a little bit of space. And write down obstructive and give yourself a little bit of space. Okay, because we're going to talk about each one of these. Okay? While you're writing, someone define hypovolemic. Loss of volume, right? Or low blood volume. Okay? Hypo is low. Volume, God bless you, meaning volume, right? Fluid. And then emic meaning dealing with the bloodstream. Okay? Hemorrhagic, what does hemorrhagic mean? Say again? Trauma, or broader is bleeding. Right? So there's bleeding and there's non-bleeding. Okay? Those are your two types of hypovolemic shocks. Okay? Has everybody got written, those 4 words written down with spaces underneath each one of them? Yell. We good? So next to hypovolemic, I want you to write down fluid loss. Do not write down blood loss. Okay? So write down fluid loss. Next to hemorrhagic, I want you to write down bleeding. And next to non-hemorrhagic, I want you to put non-blood fluid. We'll talk about that here in a second. So non-hemorrhagic would be your dehydration, right? Because you're not losing blood, you're just losing fluid. The other common with non-hemorrhagic is burns. Burns cause a fluid shift. They draw fluid out of your cells and out of your vessels, and they pull it into your muscles, which causes edema buildup all over your body, right? Which is why burn patients swell so bad. Okay? So you've got bleeding, or I'm sorry, you have fluid loss, you have the bleeding, and you have the non-bleeding, right? Distributive shock, okay, is something that goes systemic, so system-wide, okay? And this is a problem with your pipes, technically, okay? So a form of distributive shock would be anaphylaxis, which is what? Let me know. Severe allergic reaction, okay? Allergic reaction is you get stung by a bee and you get itchy, okay? Is that life-threatening? No. Anaphylaxis means your throat closes, your tongue swells, you lose your blood pressure, and you stop breathing, right? Would you consider that to be life-threatening? Yes. Allergic reaction, non-life-threatening. Anaphylaxis is the life-threatening shock symptoms that we are looking for, okay? You're going to get epinephrine as one of the drugs you can give. You do not give epi for allergic reactions, okay? You give epinephrine for anaphylaxis. Make sense? So that's one form of distributive shock, okay? Sepsis also falls under distributive shock. I always think of distributive as giving it to your entire body. And what happens with anaphylaxis, the real life-threatening piece that we worry about with, it causes your, it's really weird, it causes your windpipe, causes your breathing pipes to get smaller, and it causes your vessels to get bigger, right? So you can't breathe, and it dumps your blood volume. So epinephrine has a two-part, is a two-part drug. Epinephrine makes your breathing pipes bigger and shrinks your vessels. So it counteracts both sides of that, okay? Sepsis causes vasodilation and causes permeability of your vessels, okay? Not a lot of treatment for sepsis on our end, okay? So we got a fluid problem here. We got a pipe problem here, okay? Cardiogenic is to deal with your heart only. What do you think is the most common pump problem? What do you think? Heart attacks. Okay? So put MI, that's the term you're going to learn, right? Myocardial infarction. That's a heart attack. That's the medical term for heart attack. You'll hear us use terms MI or AMI. AMI is just acute myocardial infarction, which means it's happening right now. Make sense? So hypovolemic, bleeding, right? That's pretty easy, or fluid loss. Distributive, we talked about anaphylaxis, we talked about sepsis. Cardiogenic is to deal with your pump only, okay? Obstructive is a pipe problem. The most common one is like a pulmonary embolism, so blood flow cannot move downstream, or cardiac tamponade, which is the squeezing of your heart. Okay? Cardiac tamponade is a little bit weird. Everyone wants to put that in with cardiogenic, but your heart can pump like normal, right? There's nothing that's preventing it from pumping except for what is obstructing it from doing so. Does that make sense? Everyone always kind of gets those confused because I know it has to do with your pump, but it's a problem from something else. It's not because of your heart. It's because of an outside force that's acting upon that. Does that make sense? Say again? Yeah, so label cardiac tamponade as obstructive, not as cardiogenic. So the good news with shock is we go over it right now, and then we go over it again when we get into trauma. Okay? So there's 3 stages of shock. There's compensation, there's decompensation, there's irreversible. Okay? So compensation, this is what your body is meant to do. Okay? I will tell you, this is where you should recognize shock. Now, 5 or 6 years ago, we were inadvertently teaching EMTs to wait for decompensating shock. Because what we told EMT students was, you don't treat them for shock unless their blood pressure is less than 90 systolic, right? You have to lose 1/3 of your blood volume to mess with your blood pressure. So we were going, they're not in shock unless their blood pressure is less than 90, okay? That was a big, big problem considering it was taking much longer for us to pick up on this, and everyone was dying from trauma, right? So here's the compensating side, okay? This is where you should pick up on it. The very first thing is they have this mental status change. They're slow to respond, or they're anxious, or whatever the case might be. Their heart rate is over 100. Their respiratory rate is over 20. What is capillary refill time? How do you figure out cap refill time? Squeeze their finger, right, on the nail bed. So you squeeze it, it turns what color? White. When you let go, within 2 seconds, it should go back to red. Normal cap refill time is that 2-second or under mark. Hopefully right now, if you did it, it should be less than 2 seconds. Okay? So delayed cap refill time. Cap refill of over 2 seconds. Now, pale, cool, and clammy skin. Why does our skin in shock go to pale and cool? Yeah, your body's like, I don't care about arms and legs, right? So it constricts and starts shunting blood to your core, okay? Your body only truly cares about your brain and your heart, okay? Lungs, okay, brain, heart, and lungs. So it starts shunting away from your outer extremities. Then you start sweating, okay? Right here, if that person walks up to you, let's say they've wrecked their car, right? And they're up walking, it's 3 in the morning, they've been like, I've had 2 or 3 beers, right? And they've wrecked their car, and they are a little bit altered, which could be the alcohol, it could be shock. Their heart rate's 120, their respiratory rate's 22, they got a 4-second cap refill time, they're pale, cool, and clammy and sweating, and they don't want to go to the hospital because they're just drunk and they want to go home. Those are the patients you got to pick up on. Because they could be bleeding into their chest, they could be bleeding into their stomach, they could be bleeding into their legs, and you have no idea, right? You got to pick up on this stuff. So there are 3 stages which we talked about, okay? Compensating, decompensating, irreversible. So we're going to break it down. Compensating has increased pulse, which we talked about, increased respiratory rate. Weak pulses, where do you think that pulse is weak at? In your extremities, right? Good call. Cool, clammy skin, anxious, restless, or combative, they're thirsty and weak. Okay, we're talking about 500 to 1250 mLs of blood loss. Only about 5 to 25% of your blood volume is gone. Okay, this is a little bit childish, but this is where you do your magic work. Okay, right here is where you've got to treat it. Stop the bleeding, give them oxygen, give them fluids if you can, keep them warm, get them to a hospital. Okay? The reason why I stole this table is because it has a very, very abrupt approach to this, right? Get them the hell out of here. Get them away from you. Get them to the hospital. Okay? Notice how I put a star on this one. I don't want to offend anybody. So there's the decompensating side. Okay? Very weak or absent pulses. Their blood pressure tanks. They become severely altered or they go completely unconscious. And slow breathing, what does apnea mean? Without breathing. Okay? So they just quit breathing. This is 25 to 30% blood volume lost. Okay? That is a lot of blood. Okay? You can read that for yourself. It has a foul word in it, Anthony. Don't look at it, man. My favorite part of it is the praying helps, right? Because there's not a lot of treatment here. Okay? You can give them oxygen, and you can give them fluid, but they're still just going to start bleeding or keep bleeding, right? So you could be like, please, God, it's a lot of paperwork if this guy dies. Please don't let that happen, right? That's about all we got. Okay? Why do you think irreversible is called irreversible? They're gone, right? I love this. Stick a fork in them, he's done, right? We're toast. Now I want you to look at how much blood volume they're talking about. How much blood volume? Only 35%, which means above 35% lost, you are dead. Okay? Not even half. So you got to pick up on this stuff way before decompensating. Adults have very, very good steady decline, right? They'll compensate, and then they'll decompensate, and then they'll die, right? Kids are amazing at compensating, okay? They'll compensate, 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 and then just go into cardiac arrest. They almost have no decompensating mechanisms, none, right? The kid I was talking about, the shot with the arrow, literally went from conscious and alert and talking with a perfect blood pressure and a perfect heart rate to in cardiac arrest instant, like that quick. There was no drop. There was no nothing. He went from conscious, alert, and talking to dead with no decline whatsoever, right? Kids are known for that, okay? They compensate, 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 and die. Adults have this, okay, we don't need the arms. We can start shutting down some organs we don't need. We can really try to protect our internal organs. Kids don't have that because their volume is so much less than ours, right? So we have 6 ml, or we have 6 liters of blood circulating around. We've got 1.5 liters of blood storage in our spleen to help that compensation, okay? Kids have that, but nowhere near that much, and they don't have that good decompensating mechanism to help them out. Yeah, they skip this whole thing right here. Okay, it's pretty rare you see this. Because if you think about it, the other big thing is your normal blood pressure right now, let's say for sake of argument, 120/80, right? Their blood volume normally runs, kids, 9-month-old baby, probably like 70 as their systolic, right? So they don't have a whole lot of room to lose any blood volume. Where you can lose some because you got a long ways to go to get to where your blood pressure doesn't sustain life, right? So yeah, kids skip almost all the time this phase right here. Or they're in it, they're out of it, they're under irreversible. So those are the 3 spaces I was talking about. Intercellular, which is inside your cells. Intravascular, which means inside your vessels. And then interstitial, which is inside your, or in between those, right? We're talking about the muscle space here. Okay? So most of your water is found inside your cells. Okay? Second most is interstitial, and then there's just a little bit of that fluid inside that intervascular space. Now, as your intervascular space loses some fluid, right, then it'll pull out of your vessels, or out of your cells, and try to compensate for that. If you've got too much, then it attempts to push it out somewhere. Okay? Most of the time, if you ingest a bunch of water, which would change your fluid balance, what does your body do? What? Drink a bunch of water, what happens? You pee a lot, right? Your kidneys are like, oh, that's too much, and they just produce more urine, right? All urine is the byproduct after filtering your blood, okay? Filters all that stuff out. It takes out what it wants, okay? Medications or nutrients or whatever, and what's left is the waste, okay? If you drink a bunch of water, what do you notice about the color of your urine? It's clearer, right? Because it's just dumping the water out of your system. Okay? Now, that's where the idea of, in a survival setting, you can drink your own urine, right? The thought process of if there's water in your urine, because even if you're normally hydrated, there's still H2O in your urine, right? So there was this thought process that you could go ahead and drink your urine and gain water. I will tell you, the water that's in your urine, your body doesn't want. So you can drink your pee if you want, and it's still going to just push the same amount of water out. You gain nothing out of drinking urine. That's shocking, right? Don't eat yellow snow. We talked about this way back when you were younger. Okay? That's the whole purpose of your renal system. What happens when you go in shock is your body notices you're losing fluid somewhere else, right? Your body's like, I'm bleeding somewhere else. So it goes to your kidneys and says, stop producing urine, right? So it stops filtering your blood, and it keeps everything. So now you run the risk of infection and sepsis because it's keeping the byproduct it's used to getting rid of. In a trauma hospital, they actually account for how much you're peeing. They want to know your urinary output to find out, is your body still in shock? Because based on how much you're peeing and how much fluid your body is processing can tell us how far into shock you are, right? It's crazy how your body all works together, okay? That's a dumb picture. So brain and kidneys regulate thirst and elimination of excess fluids, right? Your blood plasma proteins pull fluid into the bloodstream. We talked about that with the pressures, right? The cellular membrane and capillary permeability regulate flow in and out. If you got leaky vessels, then you run into that fluid shift problem. Dehydration is loss of fluid. If you don't have the distribution, then water builds up, and this is where you get edema. Okay? You need to know that term. If you don't have it written down, write it down again. Edema is too much water in some parts of the body. Now, water is pretty cool. It will pool with gravity. Okay? If your patient is ambulatory or allowed to move, the fluid will build up in their lower extremities. We call it pedal edema, right? These are we talking about like big fluid edema ankles, right, or calves, right? Lots and lots of fluid, okay? If they're bedridden, it actually pools back kind of by their kidneys. We call that sacral edema, okay? So it always pools with gravity. Now, this is important. This is the subtle sign that people miss when it comes to CHF, okay? Patient calls because they're having respiratory difficulties, and you're asking all these questions, and if you never do an assessment, what you don't find is the fact that they got all this fluid build up on their ankles, okay? What we call pitting edema is if you find edema, you take your thumb and you push on the edema, okay? I've seen pitting edema that has that pit for 20 to 30 seconds, right? You push on that fluid and there's just that pit until that fluid pushes that skin back out again. Pitting edema is a pretty life-threatening problem, okay? That's a lot of fluid, okay? Does that make sense? Everyone's staring at me like they have no idea what I'm talking about. The nervous system, so you got the brain and the spinal cord. They're pretty well protected by the skull and the spine, okay? Your spine's purpose is to protect that spinal cord, and your skull protects your brain. Now, your brain is kind of a problem, okay? And by that, I mean it's a free-floating organ, okay? It can move forward and back. It can move up and down. It can move side to side, okay? It's got enough space to do so. So with head injuries, one of the problems is if you impact, let's say you run head first into a wall, okay? How many of you do that? Nobody? Liars? Good call. Thank you for being honest. So your forehead impacts the concrete wall, and your brain slides forward and smashes into your skull, which bruises the front of your brain, right? Transfer of energy says when that transfer goes back, your brain slides back and impacts the back of your skull, which means you can have a bleed or a bruise on both sides, okay? That happens side to side. That happens front to back, okay? That's a pretty big problem. Your brain is also in a very, very interesting compartment because it's fixed, right? Your cranium is a fixed vault. Does that make sense? It's not going anywhere. Your brain is stuck inside here, okay? The only exit is there's a small layer of bone in the very, very base of your skull where your spinal column goes through, okay? when your brain starts to swell, so let's say you impact it, your brain swells, hits that cavity, and pushes and pushes and pushes and pushes. Pretty soon it actually switches and starts to push in on your brain, okay? Then your brain gets shoved down through that space to wrap around your spinal cord. It's called herniation, right? It squeezes your brainstem until you're dead, okay? Herniation kills people almost all the time, okay? That's why concussions are so life-threatening, okay? Decreased perfusion to your brain causes swelling and tissue damage, causes herniation, causes you to stop breathing, causes lack of oxygen, it leads to your death, right? Head injuries is something we will be super, super aggressive about treating in this class, okay? Sports injuries, car accidents, silly stuff like that you don't think about, pretty dangerous, okay? There's a type of brain bleed that affects your arteries, which causes you to bleed out in your brain in a fairly quick time frame, okay? Those are easy to spot. The subdurals, right, that has to do with your vein, takes days, if not weeks, in some cases longer than a week to actually show up and cause damage, right? Those are the drunk guys, wreck their car, smack their head on the steering wheel, and they're like, I'm fine. They're conscious and alert. They never lost consciousness. They're not complaining of anything. They're drunk. So, you know, they sign a refusal or whatever. Or we take them to a hospital, and the hospital's like, you know what, you're drunk, your blood alcohol level is 0.09. The cop takes him to jail, he sits in a drunk tank, he sobers up, goes in front of a judge, he gets, you know, out on bail or whatever. 4 days later, never wakes up, he's in a coma and he dies, right? That stuff happens more often than we think it does. There was a 10-year-old girl in Toronto hit in the head with a hockey puck during an NHL hockey game, right? Doctor goes up and says, did you lose consciousness? Dad's like, nope. She's conscious and alert. She's not slurring her words. She doesn't have any pain other than just the one spot she took the hockey puck. No big deal. They send her to the whole, you know, you get autographs, you get free tickets, all that good stuff. They send her home. She's 10 years old. She doesn't wake up. She dies in her sleep. Right? That's the silly stuff that we overlook because of what can happen with our brains. Okay? Talk about that stuff. Nervous system dysfunctions, motor vehicle crashes, okay, falls and diving accidents. When we deal with diving accidents, it's always those, you know, you get called to a person who's drowned in a pool. You pull them out of the pool. One of your very first questions should be, why did they drown? Okay? Could they not swim? Did they have a medical issue that caused them to drown? Or did they dive in, strike their head, lose consciousness, and that's how they drown? There's all kinds of components to diving incidents. Okay? Medical dysfunction, strokes we talked about, right? Infections, meningitis. We're going to talk about this later. Lou Gehrig's disease, low blood sugar. Okay, of these, what do you think is the most common one you're going to go on? Diabetics, way more than strokes. Right? Okay? By far, diabetics is the most common. You get strokes every once in a while. Okay? Endocrine system, again, the glands secrete hormones, send the chemical message to the body to control body functions. We don't really deal with this as the big problem very often, okay? The biggest time we deal with this, we talked about, right, is the pancreas, okay? They've put in, you know, brain up here. Really, that's neurological more than it is endocrine, right? Again, you're going to have patients who have hypothyroidism or adrenal gland problems, something like that, maybe dealing with the cancer side of things, but for the most part, most of our endocrine problems, we deal with the diabetes and the pancreas issues, okay? Kidney stones and kidney infections also are pretty common. Too many hormones like Graves' disease, too much thyroid hormone, you know, heart rate issues, temperature regulations. Again, not usually the reason why you're there, but you will have a lot of patients that this is their past medical history, okay? The one times that we deal with this a little more often is when mom has delivered, we call it postpartum, right? So after pregnancy, they have all kinds of gland dysfunctions, messes with all kinds of glands, and they're trying to learn how that works, or during pregnancy, and so you might see patients along those lines. Most of the time, again, like I said, we're dealing with the diabetes side of things. Digestive system, most of the time we're dealing with this, it's going to be, you know, they ate bad food, and we're talking about food poisoning, or, you know, heartburn, and they're mistaking that for possible chest pain. We're going to talk about GI bleeds and the problems those present with. And then, of course, cancers and stuff like that can cause some pretty nasty bleeds or pain when it comes to esophagus and stuff along those lines. So the GI bleed, right, gastrointestinal bleeding, there's two sides. This is an upper GI bleed and there's a lower GI bleed, okay? I will tell you that you can have massive GI bleeds that kill people, okay? Bleeding so bad inside their body that either it's coming out rectally or it's coming out orally, okay? They're puking up like large quantities of blood, or they are in their feces large quantities of blood, okay? This is extremely life-threatening. Okay, those are the things. We'll talk about signs and symptoms. We'll talk about red flags, but kind of keep this stuff in mind when we get into it a little bit longer. Vomiting and diarrhea, biggest thing is going to be that dehydration, right? Long term, we see a lot of, we go in a lot of dehydration patients, whether it's because of the flu, whether it's because of food poisoning, whether it's because of alcohol ingestion or because of a drug or whatever. Anytime you think of vomiting and diarrhea, you think of the possibility of dehydration, okay? Also with the flu is if they have a cough, but they're not producing phlegm, right? They always have that feeling like they have to cough, but they're not getting anything up. We start thinking about pneumonia, which can cause some pretty nasty stuff. Okay, those things we kind of think about throughout the line. Immune system, not a lot of stuff we're doing with this, maybe on the cancer side of things, not being able to fight off infections, or diseases that have immune system problems, but for the most part, we don't see a lot of that. Hypersensitivity, like allergic reaction. So the common misconception with allergic reaction is your anaphylaxis is actually your body's fault, right? You get stung by a bee the first time, and your body says, you know what? I'm going to build antibodies and histamines ready for the next time that I get stung, right? So you get stung a second time, and your body over-exaggerates and dumps histamines into your bloodstream. Histamine release causes your throat to close and your vessels to get bigger, right? And you go into anaphylaxis. So we give you epi, right, or epinephrine, and it causes your breathing pipes to get bigger and your vessels to get smaller, and it fixes the problem, right? For how long, you think? 30 minutes, right? Because your body's still just dumping histamines, right? All we did is we just flipped the response the histamine created. We didn't touch the histamines. Only paramedics in the pre-hospital care setting can give Benadryl, which is an antihistamine, or diphenhydramine, right? Paramedics are the only ones. So the downfall is we give epi, and the patient's like, oh, I feel so much better, I don't want to go to the hospital. And you have to have that conversation of, in 30 minutes, you're going to go back to not being able to breathe. We need to take you to a hospital. Or contact ALS and get that Benadryl on board, okay? We're going to touch on allergic reaction much more. We're going to talk about epi. Kind of keep that in mind, though. It's exaggerated immune response, okay? It's not the bee venom that causes your throat to swell and your vessels to get bigger. It's your own body's fault. It over-exaggerated the response. Rapid drop in blood pressure, obviously, because it makes your vessels bigger, produces that edema because you get that fluid buildup around your bronchioles or around your trachea. And then, obviously, we talked about the life-threatening problem side of things. Questions? That's pathophysiology in 2 hours. No big deal. Cool? Take a quick break. Stand up. Stretch. Get some coffee.